Thank you very much. Thank you for asking me to speak here today. I would like to tell you a little bit about the MOSAICC study and really start with talking about epidemiology in myeloproliferative neoplasms in general. This is the question that I'm sure everybody wants to know. It's the question that I always get asked: why have I got this? What has happened in the background that has led me to have this myeloproliferative neoplasm? And of course, we don't know the answer to that. There are certain things that are more commonly associated. Gender, PV is more common in men, ET more common in women. Age, as in many things, these things become more frequent as people get older. And there are certain genetic factors that may be involved. The one that everybody remembers and quotes as myeloproliferative neoplasms are more common in Ashkenazi Jews. But inheritance does not explain why most people get myeloproliferative neoplasms. And really, it leaves the question of looking for the needle in the haystack. What does cause myeloproliferative neoplasms? So we looked at this, we looked at what had been done already, and what we actually did was a systematic review of everything that had been published looking at this. And we started out with 9,156 publications on causes of myeloproliferative neoplasms, and eventually whittled that down and looked at that, and there were 19 studies that had actually done that had looked at this. So that's actually not that many, and very many of these were very small studies looking at very small numbers of patients. However, there were certain things when you systematically analyse the literature that came out with being associated: family history, Jewish descent, some autoimmune conditions, certain occupations. So the sorts of things that come out from these studies, first of all, they come in two types. There are cohort studies and case control studies, which we'll come to in a minute. Cohort studies are where somebody has a large data collection of information on people in certain occupations. It's fascinating, the various groups where there is this information. For instance, somebody can look at a cohort of funeral service workers who has this information, but somebody has, and they've looked at it. And there are certain occupations from the cohort studies where there seems to be a slightly increased incidence of myeloproliferative neoplasm. So all the things listed on this slide, there's some evidence in the literature that they may be associated with myeloproliferative neoplasms, but that doesn't get you that far. Also, certain medical conditions appear in these studies more frequently, so a lot of autoimmune conditions, but these are very small numbers, but it raises the question: is there some other medical history predisposes to myeloproliferative neoplasms? Then what you do is you look further at in these studies as to has any particular exposure, a chemical exposure or anything else like that. And again, there's small bits of evidence. Hair dye was more associated, if dyeing the hair for more than 10 years was associated with ET. But there was actually, in many other studies, no association with hair dye, pesticides, solvents, etc. So again, these are all small studies, but it's all out there and published. So we wanted to look at this further. We felt that having looked at this, there was a need to try and do a more systematic study, possibly in a bigger group of patients. So what we decided we would do, because you don't have a cohort of people, was a case control study. And what you do with a case control study is that you get a group of patients with myeloproliferative neoplasms, and then you have a control group who haven't got a myeloproliferative neoplasm but are in the same area or have the same lifestyle, etc., etc. A comparative group without myeloproliferative neoplasms, and then you investigate in detail to see what things you find between the cases and the controls. So we thought this was the way to go, because it was the practical one we could do. It immediately threw up a lot of questions as to how the best way to do this is, how you recruit the controls, and lots of other questions. So it was obvious that to do this, that you've had to test a lot of these things first. So we set up a study which we wanted to do to look at many of things. We wanted to look first at how to get people involved, what was the best way to recruit patients, and particularly how to recruit controls, how many people would actually take part. We had to then develop to do this by telephone, because the idea was that you wanted to be able to interview people over the phone, and you had to then develop a questionnaire, particularly looking at the things you wanted to know about occupation, residence, lifestyle, all the different things that people wanted to know. There are actually people out there called occupational epidemiologists, and these people develop these questionnaires to look at all the different things you want to know. But we needed to get their help to develop one that would work for people with myeloproliferative neoplasms. We also, when we were doing this, thought we would like to look at quality of life at the same time. And if you do any group of patients, you get them together, there's always an idea that it would be very good to actually get DNA, to get samples from them as well. And if you have a group of patients and controls, then what you really want is DNA from both, so that you can then do further laboratory studies. So we wanted to do all of that. And we then set up the MOSAICC study, which was funded by MPN Voice entirely. So we applied to them, and they gave us a grant to do the MOSAICC study. And that is what we've done now. This is MOSAICC, which is the myeloproliferative neoplasms, an in-depth case control study. We spent a long time thinking up MOSAICC from that. This was a pilot study to look at all these things. So it was an exploratory case control study. We aimed to recruit 100 patients with classical myeloproliferative neoplasms, and the idea was to get 200 controls, and we would look at two different ways of getting controls, either getting them as non-blood relative friends, so that is, you ask the patients could they nominate somebody who would volunteer to be a control. And the idea of that is that they are, if they're non-blood relative, so wife can do it for husband, they don't have the same genetic background, but they'll have the same exposures and background. So there's pluses and minuses in doing that way, because they're often very close together. The other way is to just get people at random, and the way you do that is through the GP surgery. Can you get people off the GP practices to volunteer to do this? And there's, as I say, there's advantages and disadvantages with both methods, but the idea is how can you actually recruit the controls? We also then wanted to look at all the different things, the procedures, response rates, make sure that we'd got the questionnaire that worked, look at, see could we get biological samples, and also we decided that it would be very interesting to look at the quality of life, not just in the patients, but in the controls as well. So, how did we get on? Well, this was a pilot case control study in Southampton and Belfast, because that was the two sites. We actually over-recruited patients. We got 106 patients in. Why can you say you're doing 100 and get 106? Well, if 106 volunteered by the time you stay, you take the whole 106. And they were distributed in the sort of area you want across the three diseases. Controls, remember we aimed for 200. We got 127, but as you can see, big difference, despite a lot of effort, only 46 from the general practices, whereas 81 from non-blood relative friends controlled. So that's the first answer from the study, that it's actually much easier to, if you're going to do this to get the controls, you probably have to do it through friend, non-blood relatives to get the numbers. This just shows you a little bit across the cases again, and again makes the point that of those approached, of the controls overall, only 31% were recruited, whereas of the cases, 67% actually volunteered. So the patients are very happy to do it. Getting controls is always an issue. What about the results then from this? What did we find out apart from that? Well, there were a number of things that from the study came through clearly. First one is quite interesting. Some people in a randomised fashion were given an incentive and some people weren't. The incentive is something, it was a £10 check as a sort of, does that help to people think they're getting something out of it? And it basically makes no difference. Incentives do not help participation. And that's quite interesting because raising a £10 check actually costs about £30 through a system. And then if people don't cash the check, there's all sorts of issues with that. So that's actually an important piece of information, that people are either going to do this or they're not. The other thing is we did some, we were allowed to have one piece of encouragement when people were asked and approached. You can't keep on and on hassling people, you know, they're either going to do it or not, but we were allowed ethically to do one piece of encouragement, and we randomised by that as to whether writing them a letter or phoning them up was a better way of getting people to participate. So those who'd been approached and hadn't participated, they either got phoned or a letter, and it was clear that a phone call was much more effective than a letter. Quite often you got people, when you phoned them up, said, oh, I meant to do that, but I forgot. And sometimes actually you got a clear answer, no, I'm not doing it. But that's fine. But you know, it was much more effective, whereas a letter, I think it just probably went in the same pile as the to-do list. And the other bit, which was quite interesting, all participants consented to provide at least one biological sample. So collecting DNA on the back of this was very feasible. We also did, as I said, a symptom assessment on everybody, on both patients and controls. We used the MSF-SAAF assessment. And this was actually the first study that this has ever been given to the normal controls as well as the patients. And very interestingly, what you see, this is called a spider plot. And what this shows is that this sort of gives it, go around the 360 degrees, the scores for symptoms at each one. And the further out you are, the higher the score. So the red line is the patients and the blue line are the controls. And you can see that the patients have much more symptoms than the controls. You all knew that, but it's actually very useful to actually look at it and show that. And you can also see in this the symptoms across the different patients. So different line, purple for PV, blue for ET, and black for myelofibrosis. So you can see slightly different symptom profiles for the different diseases. So that was what the pilot was set up to do, to look at all these things to see how you would do a bigger study. But we actually got enough results that we were able to analyse those and get some changes. And this is again looking at the patient characteristics, but when we actually looked at the various factors, there are a few things that come out as significant. So the first one is that some childhood factors, so myeloproliferative neoplasms are more common in lower social class groups, and with that, it's also more common in people who in childhood had more than one child to a bedroom, which these two may of course be linked in some way. Other things, lifestyle factors, well, what came out as significant, not surprisingly, and as in with other studies, having smoked in the past is more associated with myeloproliferative neoplasms. And then the good news ever taking alcohol is less associated with myeloproliferative neoplasms than in the normal controls. So alcohol might protect against, no, but that's not probably correct, but there certainly was there. Lots of things, the studies, then we looked at the environment, and again in this pilot study you can see that having paint in the house is actually less associated with myeloproliferative neoplasms, and that's interesting because you're looking at all the environmental things, and that's one that was thought. Most of the rest of the stuff, there's no difference between the patients and the controls. So just to sort of, because I've given you big long tables to put this in, pull out the things a little bit more. More common in myeloproliferative patients than controls, growing up in a house with one or more child per bedroom, i.e. a higher household density, cigarette smoking. And the one environmental thing that did come out, although it needs teased out more, is having CT scans. The problem with this is, of course, some of the patients have a lot of CT scans anyway as part of their diagnostic process, so the significance of that is not clear. But certainly it came out that myelofibrosis patients there were 10 times more common CT scans than in controls. Not associated in our study, blood donation, and that is quite important because there was at least one study in the past where it seemed to be associated. Hair dye, everybody will be glad to know, and we did not see any association with autoimmune disease, but don't forget this was the pilot. So that was MOSAICC, or the MOSAICC pilot, which is now finished, completed. That's the whole team, including the epidemiologists and our colleagues in the States and Australia. And we now have the information that we need to do a large definitive study. So we did 100 patients and 200 controls. What we now need to do is roll all that information over into 1,000 patient study and 2,000 controls. So we have been attempting for the last couple of years to get the funding to do that. We now know what we need to do and have the ability to do it, to get the funding. We started with the large grant-giving bodies who declined, although they said it was a good study, and we've been trying to put it together over the last couple of years. MPN Voice have committed, LLNI Northern Ireland has committed, we've got an enabling grant, we've got about half the money, and we've been to Novartis and we're still waiting to hear from them. They keep making the right noises but haven't totally committed yet, and as soon as they commit, we are actually ready to go to run a further study which will be both throughout the UK, and actually as soon as we start, our colleagues in Australia and in the US have said that they will be able to do the same thing with their cohorts of patients using all the information that we have. And the idea would be that then if we have a great big study, we really will be able to look at these things and see if anything comes out further associated. So thank you very much. We've actually done it.